good afternoon, everyone. I'm Alessandro Martimino, Membership Coordinator of TUGS. I will lead this TUGS Scientific Sunday, the 7th, on behalf of Dr. Pauls, because he's in duty due to extra duty of coronavirus spread in Netherlands. So today we will have 4 presentations and a keynote lecture by Dr. Taha. And this meeting will be moderated by Dr. Sul, Dr. Gul, and Dr. Dasari. So I can give the word to the first presenter, that will be Dr. Almonid. Can you hear us, Dr. Almonid?
Yeah, I can hear you.
Okay, so please, you can start, you can share your screen.
Okay.
Thank you.
Okay.
Perfect.
Yeah, can you see it okay?
Yeah, thank you.
Okay. Hello, everyone. I'm Ahmed Al-Munib, one of the general surgery registrars in Queen Elizabeth Hospital, Birmingham. So I'm going to talk about the neoadjuvant chemotherapy and its effect on the TNM staging and the diffuse gastric cancers. So diffuse gastric cancers are accounting for 30% of all the cases of gastric cancers. And unfortunately, it's observed more in the younger population rather in comparison to the intestinal type of gastric cancers. And also, unfortunately, it's with a poor prognosis and about 3 to 10% of 5-year survival. That's according to various studies. We currently treating the gastric cancers with the MAGIC protocol, which increased the 5-year survival from 23 to 36% for the patients with resectable stage 2 and stage 3, but that's all across all the types of gastric cancers, which includes 6 cycles of chemotherapy, 3 pre and 3 post chemotherapy, and it insists on EF chemotherapy. Sorry. Our hypothesis is the neoadjuvant chemotherapy, does it make no difference with downstaging of the and the outcome of the diffuse gastric cancer or not? And should the diffuse gastric cancer patients proceed straight to surgery or not? So we gathered all the data for stage 2 and 3 gastric cancers, diffuse and intestinal types from 1st of June 2001 to 22 of February 2021, who underwent surgery. So we excluded all the palliative and the non-surgical one. We had 121 patients in total, divided into 2 groups, an intestinal type and diffuse type. Intestinal type has 83 patients, and diffuse type has 38 patients. The intestinal type also divided into who received neoadjuvant chemotherapy and who went to surgery. 44 received neoadjuvant chemotherapy, and 39 only went to surgery. Also, the diffuse type divided in the same groups. 27 received neoadjuvant chemotherapy, and 21 went straight to surgery. And the results as follows. As you can see, the age is a bit, they are a bit younger in the group who received the neoadjuvant chemotherapy, because I think the older population wasn't that suitable for chemotherapy. The preoperative T stage was almost the same, and the preoperative end stage was almost the same. The postoperative T stage remained as it is, but the postoperative end stage, there was a big difference in the diffuse type. A comparison between the groups of the intestinal type and the diffuse type who received neoadjuvant chemotherapy. As we can see, the preoperative end stage was significant, and the tumor regression grade was 4 in the two groups, which is important. So, furthermore, and in details, there are no significant differences in the pre-chemo T stage, post-operative T stage, and neither do the end stage in the intestinal group. And in the diffuse gastric cancer group, there was no significant difference in the T stage, but the N stage was remarkably increased post-operatively. And then for the survival for the 4,000 days and more, we can see that the group who received the neoadjuvant chemotherapy has survived more, which is a significant difference between the non-neoadjuvant and the neoadjuvant chemotherapy. So in conclusion, it's most likely that the end stage is understaged by the radiological measures in diffuse gastric cancer rather than the progression of the lymph nodes disease despite the neoadjuvant chemotherapy, and that the CT scans are not the best method to accurately detect the end stage in diffuse gastric cancers. And the neoadjuvant chemotherapy is associated with better survival in both intestinal and diffuse gastric cancer. Thus, this disproves our hypothesis. And this concludes my presentation today.
Thank you, Dr. Almoni. Thank you a lot for your presentation. Really interesting. Do you, the moderator, have some question to Dr. Almoni or someone from the listeners?
Come again, sorry?
Okay.
Can we go back to slide 9, please? While you guys talk, can you go back to slide 9?
9. The survival one.
Why is it censored?
What do you mean?
It says diffuse surgery alone censored, intestinal surgery alone censored. What does that mean?
I'm not quite sure right now, but I will get back for that after I discuss with my consultant about this, because he was the one who get this figure. Unfortunately, I couldn't ask him about these details.
Okay.
Because your lines are very similar. The colors of the lines are similar. So it's hard to know which is your.
So the red one
is NAC.
Is the intestinal type.
Yeah.
And the blue one is the
nicely.
diffuse. Can you see it now?
Yeah. I just want to know why censored. And can we go back to slide 6, please?
Yeah.
Yeah, thank you. You guys carry on. I'm just looking at trying to understand the data.
Okay.
Should I ask a question meanwhile?
Yeah,
please.
Yeah, please.
Dr. Ahmad, that's a very interesting study. I don't deal with gastric cancers. I do liver and pancreas, but certainly an interesting topic, neoadjuvant treatment and downstaging. Do you think there is, what is the point you're saying at the end of this? Should you be staging your lymph nodes, gastric lymph nodes in diffuse cancers with endoscopic ultrasound to get better staging? That's one question. And the second question is, you are comparing the preoperative radiological staging with postoperative histological staging. Is that the right methodology, you think, or is that the best methodology you could come up to?
So what we could gather is we usually use the CT to stage the lymph nodes. But when we compare to the actual, I'm not sure that the comparison between a radiological method and a histological method would be the best, but the most accurate would be the histological type, the histological study. And I don't think we can achieve that pre-operatively. We have to go for operation.
Okay.
The data that you're presenting is very interesting. Because you have basically a group. If you go back to slide 5, you have an auto control. But the methodology of which you're presenting, because you have surgery alone and surgery, so you can actually, the people who go directly for surgery alone can be people who are your auto controls. By the way, diffuse is n equals 48, not 37. Yeah, unless you got a number in n 21 and 27 wrongly, so it equals 48. So you could have made quite a good case to look at your accuracy of staging in your slide 6 by looking at your staging accuracy, and the slide 6 isn't the appropriate kind of slide to make. If you see what I'm trying to get. So firstly, in the presentation, you must always check your sums. Make sure the 21 plus 27 equals to 48 rather than 38. And if you're looking down the second column, your NAC column, it'd be nice to know how many people had stage migration from your C to your YP, and how many people who had stage migration in your surgery alone. So the way you present your data isn't, you could have made more excitement of this data, basically. I don't know what my other moderators think. And you could have said, look, the surgery alone patients is a control for my radiological staging. And therefore, I can tell you whether radiological staging is good or poor, and whether this is a stage migration from NAC or not during NAC. However, the stage migration may not matter because my survival studies show that these patients have lived longer. Yeah, and then you can look at your stage migrated patients to see whether they're the people who died early. So in other words, you're proving that biology is king. So anyway, you could have made a lot more of this story than what you're showing. And you got nice data there, but you've not done it well.
Okay.
Can I just say that? I don't know whether my fellow moderators say the same. By the way, I worked in Birmingham. I worked with John Whiting when he was a first-year locum consultant. Yeah, so that so some of these patients are patients that I've operated on. Yeah, so that's where I come from. But I just think that your data can be presented better, especially this slide 6 could be done a lot better, and you could tease the data a bit better because you got longitudinal and cross-sectional data, and therefore it could be quite a nice paper. Yeah, but anyway, we've changed our chemotherapy regimen as well, so you may want to look at the different types of NAC.
Okay.
Yeah.
Thank you, Dr. Thank you, Dr. Sun, because like the point of our meetings are to share the expertise of the expertise of our moderators to increase our work as juniors. So thank you a lot for sharing your expertise.
Yeah.
So we can continue. Thank you, Dr. Almonid.
Yeah, thank you so much.
Now it's Dr. Nafld, sorry for pronunciation.
Yeah.
Nafld, yeah.
It's Nolyan, but yeah.
Nolyan, okay, thank you.
Okay.
You can share your screen when Dr. Almonid will stop to share his screen.
Okay, sure.
Yeah. Okay.
Perfect. We can see it.
Okay. Good afternoon. My name is Urkan Oljan, and I'm a medical student from Medical Faculty Ljubljana, Slovenia. Firstly, I want to thank you for the opportunity to present the results of our research. Our research was about Sibo, which means small intestinal bacterial overgrowth in patients who underwent bariatric bypass surgery. Firstly, to understand Sibo, we must define intestinal microbiota, which is the entire population of microorganisms that colonizes a particular location. And the intestinal microbiota is influenced by environmental factors, for example, diet, and host physiology, for example, age, comorbidities. Then dysbiosis means an alteration of the microbial composition. Sibo is a condition with an increasing colonic type bacteria in the small intestine, and it can be asymptomatic or can present with the symptoms of fullness, abdominal pain, flatulence, diarrhea, malabsorption, or in severe cases, deficiency syndromes. In obese patients, there are some changes in the microbiota, and microbiota is thought to be a potential factor which is contributing to obesity. It comes to changes in two dominant philia. As you see here, it is an increase in the firmicutes and decrease in the bacteroidetes. Therefore, nutrients take over the role of signal molecules. Because of this comes to disruption of intestinal epithelium and translocation of LPS bacteria and bacteria metabolites into the bloodstream. LPS, as of lipopolysaccharide endotoxin, is an essential molecule of the cell walls of gram-negative bacteria, such as Bacteroidetes, and then stimulates adipose tissue deposition with increasing inflammatory rate and insulin resistant, which is an important support of metabolic endotoxemia. Also, other molecules are included, for example, serum amyloid A proteins. And these proteins reach higher blood levels in obese patients and are involved in nuclear factor kappa B dependent response to LPS, and then LPS and potentially also other byproducts of microbiota might elevate cytokine expression, and this leads to and this exacerbate chronic inflammation, which is observed in obesity. Another important thing is gut-brain axis with multiple afferent signaling pathways. And a dysbiotic microbiota is thought to alter the communication between the gut-brain axis and is contributing to mood alterations, for example, anxiety, social alterations, and also cognitive dysfunction. Chronic alterations in gut-brain axis are associated with neuroplastic brain changes, which is important in our patients because obese patients then crave or they have preference of different types of food, for example, more caloric food. Another important topic is Nafld or non-alcoholic fatty liver disease. The spectrum of Nafld is from fatty liver to non-alcoholic steatohepatitis, and which can lead to cirrhosis and is associated with hepatocellular carcinoma. The prevalence is up to 90% in morbidly obese patients, and Sibo is involved in the pathogenesis. The gut-liver axis is considered to play a critical role in the development and progression of Nafld, and the integrity of the epithelial barrier is crucial to protect the liver against the invasion of microbial byproducts from intestinal gut microbiota. So what have we done? We tested 55 patients who underwent standard bariatric bypass surgery after 2017. Average preoperative BMI was 46 kilograms per square meter, and preoperative weight loss was 60.5 kilograms. We excluded patients who used antibiotics, laxatives, or prokinetics, and then glucose hydrogen breathing test was performed. The rise of more than 12 ppm during the 2-hour test was deemed as positive result, and all our patients filled out the questionnaire about demographic characteristics, symptoms, eating patterns, and general health. Then liver biopsies were taken during the operation, and Nafld activity score was evaluated for liver damage, and we analyzed results using statistical tests. On this picture, we can see how the test is performed. So the patient drinks glucose, and if Sibo is presented, glucose is fermented in small intestine. As a byproduct, there are some gases produced, hydrogen and methane, which goes into bloodstream and then are exhaled by the lungs, which we can measure. And here on this picture, we can see the curve in Sibo positive test. So if the curve arises above the 12 ppm above the baseline, which is here, the Sibo test is positive. And this test is validated standardized test for Sibo, introduced for official use by American Society for Gastroenterology in 2017. Out of 55 patients, 23, around 42% were Sibo positive and 58% were Sibo negative. We found that some comorbidities, for example, lactose intolerance and diabetes 1 or 2, or problems after drinking milk were more common in Sibo positive group. There were also more common use of antibiotics as a child in Sibo positive group, and the eating pattern was a bit different. There was a worsening of symptoms after eating fibers in Sibo positive group. We found some border p-values that was in symptoms, flatulence and bloating and skin problems. We found no statistically significant differences in age, gender, BMI, socioeconomic status, or degree of education. And there was no statistically significant differences in losing weight after the operation between two groups. Here we evaluated the effect of Sibo on social activities. And we can see, for example, in this column here, where we present the negative effect of physical problems on social activities, that almost 100% of patients from both groups had some problems in social activities, but actually there were no differences between the two groups. We also evaluated Nafld activity scores in patients, and we saw that the average was higher in Sibo positive patients with the average of 3.32. So conclusions, we found out that most common symptoms of Sibo after bariatric bypass procedures are flatulence and bloating. Then second, eating pattern is a bit different. Fibers are worsening symptoms in Sibo positive patients. We propose glucose breathing test as a simple non-invasive diagnostic tool. And we propose mandatory Sibo testing after bariatric surgery procedures. Why? Firstly, because of systemic effect and the correlation to liver disease that might worsen in positive patients. For example, obese patients have pre-existing liver damage, and if they get Sibo, the liver disease might even worsen. And secondly, clinical presentation from Sibo positive and Sibo negative group does not differ, so we must test for Sibo. And we recommend Sibo testing prior any metabolic surgery due to proven Sibo involvement in liver disease progression. But we have no data for non-standard limb formation, so we think that longer exclusions might trigger liver deterioration. Thank you for your attention, and now I'm of course open for a discussion.
Thank you, Dr. Nurian. Really well presented, a well-designed presentation. We have a question for you from Dr. Sharif in the chat about how did you find this study, like, because you didn't show a disclosure slide. So
how did we found it? So the money, or what exactly is the question?
I think that it's speaking about the money.
Okay, this study was founded by UMC Medical Center Ljubljana, and it was research which the results will be presented as we have like a Presheran Award, which is for young researchers in our faculty. So we have some foundation for research.
Okay, interesting.
Yeah.
Great opportunity for your university. Yeah.
Yeah. Okay. Thank you.
Thank you a lot. Thank you a lot.
Okay.
Okay. Okay. There is another question from Professor Sharif. So if the patient is Sibo plus, what should be done?
Yeah, there is a treatment with antibiotics. It is a non-systemic gastrointestinal specific antibiotic, rifaximin, if you know it. We have treated our patients who were Sibo positive with rifaximin, and there are, in literature, we found out there are around, the rifaximin is efficient in around 40 to 70% of patients, but we are still treating our patients, so we don't know yet how much patients in our research will help from the antibiotic. But as we contacted them, almost all of the patients had their symptoms improved after we treated them with rifaximin.
Thank you. Okay, so now we can go on. Now I want to invite Dr. Boru to present his screen. Okay, I think. Oh, Dr. Boru, are you here? Okay, so Dr. Sa, maybe you can go with your keynote lecture because Dr. Frattini is in the OR now, and Dr. Boru is not answering to me. So maybe if you want, you can go with the keynote lecture now, and we will do the next two presentations after your keynote lecture.
Sure, it would be my pleasure.
Thank you, Dr. Tawa.
I'm sorry, just a minute.
Yes, don't worry, don't worry.
All right, so shall I share my screen?
Yeah, thank you.
Well, you have disabled me. You have to give me the option.
No, yeah, I gave you the co-host power.
Okay.
Thank you.
Right. So, can you see it?
Yeah, perfect.
Right. So, thanks a lot. Thank you for this great opportunity to speak to one of the very quickly growing groups. And I told Kamal, I believe in a couple of years, we probably will be the biggest body, the scientific body in the world, inshallah. It'll be a pleasure. My name is Safwan Taha. I'm a consultant bariatric surgeon, bariatric and metabolic surgeon, and I work in Abu Dhabi, the capital of United Arab Emirates. It's a wonderful place. This is my hospital. I mean, the hospital I work in, it's not mine. It's a 250-bed hospital, tertiary hospital. And we do, I would say, 95% of whatever can be done apart from transplantation. I'm also adjunct clinical professor of surgery at Mohammed bin Rashid University in Dubai and Sheikh Khalifa University in Abu Dhabi. I'm also governor of the UAE chapter of the American College of Surgeons. It'll be my pleasure today to talk to you about obesity. It's bariatric surgery, who, why, when, and how. The idea was to present bariatric surgery to non-bariatric surgeons. There are quite a few things that probably not very well known about it. I'll try to be very quick as possible. So what obesity is, we all know obese people as, merry people. They generally smile. They bring a lot of joy into any company, but it's not actually a laughing matter. It's a serious problem. Nothing else. I don't want to lose time about those. I just wanted to present what is obesity, how do we measure it, what are the various methods of managing it. It's a big problem. You can read the data. A lot of people are getting more obese. And as you can see, around 20% of those people have more than 45 kilograms of weight in excess. And this number is growing, as you can see, to the point that it's becoming more or less an epidemic, an undisclosed epidemic. And we need really to have campaigns to solve obesity. One of the interesting data is that all over the world, I don't know how much is the number, but we are operating on less than 5% of the people who are eligible for bariatric surgery now. And the number is increasing. So it is a big problem. What's the reason of obesity becoming a problem over the past few years or decades very quickly? It's a lot of things. We are consuming foods that have much higher calories than before. And then our portions are much bigger, and I'll show you. Our lives are back in the college, I was mostly walking rather than driving. I didn't have a car. Most people didn't have cars probably 30 years ago, and walking was not a sport. It was a daily part of your daily exercise. life, and we are now using it as a sport. So it's a much more sedentary life, and of course there's always some sort of genetic predisposition obesity. This is the hamburger and the popcorn like 20 years ago, and if you compare it to the standard burgers nowadays and the standard popcorns nowadays, you can see the difference per person. And I don't want to talk about soft drinks. So nobody even drinks the standard cup. There's the big cup, and there's the, I don't know, super big cup, and there's the double cup, and there's the mega cup, and I don't know. They come up with all of things to make us consume more calories and gain weight. One other thing is we have, I mean, solving any problem starts with recognizing that it exists. A lot of obese people don't accept the fact that they're obese. I asked a lot of patients with severe obesity, which is the highest degree. I'm telling them, if you know that there are 3 degrees of obesity, which one are you? 1, 2, 3, depending on severity. Very few people say that we are in severe, out of the severe group. Mostly they say stage 2, and some of them stage 1. And even once you recognize the problem, you have to start solving it. I mean, no, I'll do that tomorrow. Oh, tomorrow I'm busy, I have a meeting, I'll do it the day after tomorrow, next week, after the vacation, and so on. And we end up not doing anything. So we have to recognize it and start solving it. It's a big problem. There's no need to lose a lot of time. 2015, this is the top, those are the top 10 fattest countries in 2015. And, you know, the list is changing. The states, I don't know about the others, but United States and UAE are still among the top 5 today. So it is a big problem depending on the country where you are. And it's a complex disease. It's not like something that you can solve with one step or one modality or one effort. It's a complexity of the environmental and behavioral and genetic factors. I would say genetics, I mean, at least up to our knowledge now, plays the least important role. It's a disease anyway. 2013, the AMA, American Medical Association, recognized obesity as a disease and it's listed in their disease list. It's not a lifestyle issue anymore, as long as your BMI is more than 30, as you see in a minute. So who is considered to be overweight? In the 50s, it was a life insurance company that brought up those height and weight tables, and you can cross-link the height and weight to see whether you, when you pass the limit, then you're obese or not. I'm sorry, not anymore. Now we are using the BMI, which is the body mass index. It's not the most accurate tool. It's not the best tool. It has a few shortcomings, but it's all that we have now to label patients and classify them into a different state of obesity. How to calculate your body mass index is very easy. Your weight in kilograms over your height in meters squared. So if you're 70 kilograms then, and you're 1.7 meters, then you will divide 100 kilograms over 1.7. I mean, you multiply 1.7 by itself, and then you divide the weight over that multiplication. Of course, it's in kilograms and square meters, and you have to make the changes if you are using other units. You cannot use pounds or feet here. The guidelines, well, there's if the ideal weight, the models should be between 18.5 and 25. Below 18.5 is famine or something. It's malnourishment. It's something. It's a disease. But 18.5 to 25 is the ideal. If you're up to 29.9, then you're overweight. You're not ill. You don't have obesity. You don't need to take medications. You can do probably with exercise, lifestyle modifications, excepting if you have other diseases. Obesity as a disease starts with BMI of 30, and that's the first class of obesity, class 1 to 34.9, class 2, aka morbid obesity, from 35 to 39.9, and severe obesity or super obesity is above 40 kilograms per square meter. Anything of those can come to you with obesity, including cancer. Yes, including cancer. Cancer, there's data with significant statistical values that connects certain cancers to be higher with obese patients, and those are the main diseases that can come with obesity. But there are so many other things that can come with it, and it does affect actually death rate. There's now solid data that shows that patients who are above than 50 BMI have up to 15 years shorter lifespan than their peers who are less than 40 BMI. It's a big thing. Yeah, yes, it does affect your lifespan, and it's on the increase. If you can see here, over the next 10 years, obesity will climb very quickly all over the world. It is a big problem. How do we treat it? Well, treatment is, we have so many modalities. There's a medical treatment, there's the so-called non-gut offending modalities, and I'll talk to you about them. And there's the endoscopic management, or of course there's the surgical. And with non-gut offending modalities, we mean the vagal blocking therapy and the intra-gastric balloons. With endoscopic modality, we have the endo barrier, the POSE, the primary obesity surgical endoscopy, and the ESG, which is the endoscopic surgical sleeve gastroplasty. Medical treatment is on the increase actually now, and so many medications, injections, tablets are there. But bear in mind that if you go to the guidelines, medical therapy does not really give serious outcomes in BMI above 33 or 32. Medical therapy is for early obesity, class 1, early class 1 obesity, and it's a combination of diet, of exercise, and by exercise you mean ideally 40 minutes 5 times a week. Behavioral modifications, but again, those are very much limited because it's a disease above 30, and the drugs that act mostly through 3 mechanisms. They are either appetite suppressants or stimulants. I mean, brain stimulants. There are some of them are antidepressants. The most famous one now is a tablet called Contrave, and some of them reduce fat absorption. And most of those drugs that reduce fat absorption are not in practice nowadays because they have a rather bad effect on the liver, especially, and less on the kidneys if you use them for a relatively longer time. So it is a limited sort of resource, and disadvantages are so many. Most patients actually, I would say almost all, will regain all of their weight or most of it within a short time, much shorter than 5 years, once they stop the medication or the diet. Average amount of weight loss is much less than 40 pounds. The average weight loss is, I would say 20 pounds max. Drug therapy can cause certain severe complications that are not common, but they are serious ones that happen. The big thing here that even in our country where insurance is very much developed, I would say here, all insurance companies don't cover medical therapy for obesity. They cover it for diabetes, but not for obesity without diabetes. The other thing is people, I mean, they don't maintain long-term treatment and medications. You have to take them for 4 to 6 months without interruption, and not a lot of people continue on those regimes. And the other negative thing about it is the yo-yo effect. It's ups and downs, like a zigzag, and that affects actually the BMR a lot, and eventually they don't lose weight. The bottom line, medical therapy is good when used wisely for low BMI, I mean, low first-class obesity. Unfortunately, it's being used commercially by a lot of people. So what is non-gut offending? the V block. Let's.
Surgery.
Can you hear the voice of the presentation?
Leads onto the vagus nerve trunks at the gastroesophageal junction through small incisions created as part of a minimally invasive laparoscopic procedure. The leads are connected to a subcutaneously implanted neuroregulator that delivers high-frequency electronic pulses to intermittently block vagus nerve activity. The device is designed to be non-invasively adjusted, deactivated, or reactivated.
And that's the vagal blocking therapy. It's good if you know where and to whom you apply it. And that's not our topic today. So it's of limited use, and it's used in selected centers. It's not widely applicable for a lot of reasons. And the outcomes are not very much impressive, to say the least. Intra-gastric balloons, on the other hand, are a totally different issue. Intra-gastric balloons are effective, again, for two approaches. For low-end first-class obesity, like up to 33 BMI, they can be very effective, especially now there's emerging data if you combine them with medications, like with Contrave or Saxenda, or even the Ozempic, the latest liraglutide. So they are effective. The other modality is you use them to downgrade high BMIs. Patients who have a BMI of 65, you put a balloon probably twice over a year to make them like 52 or 53 to reduce their obesity and risk factors. But I can't use them for this group as primary therapy. This is the most famous, the first FDA approved balloon, which is called the Orbera. I'll show you. This is an animation of it. It's a balloon that is inserted endoscopically and removed endoscopically after 6 months. The average weight loss with balloons, companies claim that it ranges between 16 and 6 and 15 kilograms. The average actually the real average weight loss, if you're not using additional measures, is mostly around 8, sometimes 10, but mostly around 8 kilograms over 6 months. So that's the Orbera balloon. And then that's the SPATS balloon. That's the only adjustable intragastric balloon, and you can keep it for a year. I don't personally like it because I've endoscoped patients after that year, and the vast majority, the stomach is markedly inflamed. I stopped using it for some time, but that's me. That is adjustable. You can pull this out under sedation, conscious sedation, and you can adjust the balloon before removing it. This is the first swallowable balloon, the O balloon. It's a capsule. I'll show you an animation. But that one, this is the Orbera is 500 cc. The SPAT is 500 cc, but you can adjust it. The O balloon is 250 cc. So you put one, and then you can add up to 2 over the next 2 weeks on weekly intervals. And this is done in the radiology department. No sedation, nothing. You don't need anything for the insertion, but you will have to remove it endoscopically of course, on outpatient basis in the endoscopy department under conscious sedation. And this is the latest. This is the first and the only so far balloon that needs no intervention at all. It's called the Ellipse Balloon. The patients swallow it in the endoscopy department. I'll show you an animation. And then this valve it would dissolve in 4 months and 2 weeks, and it will pass through the intestine with bowel motion. And again, but this one lasts for 4 months, 4.5. Again, they advertise 8 to 15 kilograms. I have patients who lost up to 20 kilograms, but that's the 3-4% extreme. And I have patients who lost like no more than 4 kilograms. That's the other extreme of like 3-4%. The vast majority of my patients, without any other thing, lost between 8 and 10 kilograms, which is not bad actually if you are talking about a BMI of 32 or 31. And this intragastric balloon is the one that really went out of popularity. It's called the Reshape Balloon. It's a double balloon. Every balloon takes up to 450 to 500 cc's. This is the one that is mostly used for downgrading patients from 60 BMI to 52, 53 or 54. It's very annoying. It's a lot of things about it. It's not very successful. It's not commonly used, but it's there. It's called Reshape, just in case you hear about it. And this is the Orbera animation. You introduce the balloon through the endoscope. And I'm sorry, you introduce it alone, not through the endoscope, but then you introduce the endoscope to check that it's in. You inflate it, and then you just pull the tube out, and it acts through main mechanisms. It fills the stomach almost 1/3, so you eat less, and the weight itself will stimulate the pressure receptors and make you feel later like you're full. And then 6 months later, you just puncture it, and then you take it out under vision with endoscopic forceps. That's the Orbera balloon. The O balloon, on the other hand, is different. You can hear it? You can hear the voice? So in the radiology department, the patient will swallow it. I don't think we need the voice, but anyway, it's music to ease the situation. That's a 250 cc, mind you. It's not as big as the others. Again, you inflate it. By the way, the other balloons are inflated with saline. This one is inflated with air. That's the only balloon that's inflated with air. So that's why it floats up the food and fluids. So it will give you a partial sensation of satiety and helps to reduce the amount of weight eating. And of course, as I said, one balloon is never enough. We always put 2 at least in a weekly intervals, and sometimes you go up to 3. But most of the patients I put a balloon for, see, now you suddenly feel that you're full and you don't eat more. You can put another balloon, and you can put a third balloon. The new balloon actually put it out of practice because it's, again, much easier. That's the Aldorian Ellipse Balloon, and that's the balloon that
swallowed in a doctor's office without endoscopy or anesthesia. The ellipse is packaged into a capsule and attached to a thin, swallowable delivery catheter. The catheter is long enough so that once the capsule is swallowed, the balloon can be filled from outside the mouth. Once the capsule is swallowed and enters the stomach, it degrades. The ellipse can then be filled with 550 milliliters of fluid in under 10 minutes. After filling is complete, the catheter is detached and removed from the mouth. The ellipse fills the stomach and can assist you in feeling full and eating less. This leads to weight loss over the multiple months the ellipse is present in the stomach. While the ellipse is present in the stomach, you are encouraged to lead a healthier lifestyle and use the ellipse as a tool to assist you on your weight loss journey.
Yeah, but it doesn't do it this good.
The ellipse contains a release valve that opens by itself at the end of therapy, allowing the device to empty. The empty device is small and flexible, allowing it to transit the gastrointestinal tract until it is excreted. Speak to your doctor to find out if ellipse is right for you.
And finally, the Reshape, I don't know, just looking at it, but for the sake of time, this is very different than the others. It's huge.
Reshape Duo is the first and only non-surgical dual balloon treatment for weight loss. While the patient is under deep conscious sedation, an endoscope is inserted through the mouth into the stomach. The uninflated balloons are advanced over a guide wire and are precisely placed in the
That's the only balloon that's inserted over a guide wire because it's complex.
Each balloon is inflated independently with saline.
And as you can see, it almost fills the stomach.
The device is released and remains in the stomach.
Very heavy, almost 1 kilogram.
Built-in portion control. The balloons balloons do not change the stomach's anatomy. They simply occupy space to reduce the capacity for food. The dual balloon is stabilized with an endoscope fitted with a proprietary suction cap. Each balloon is completely drained in a controlled manner. A snare securely lassos the deflated dual balloon around the flower tip. Then, the device is removed through the mouth.
So now we go to the endoscopic model.
Prof,
Yes.
can I ask you if we can go with other presentation, because then we will not have enough time because it's 51.
Okay,
I'm really sorry. It was really, it's really
fine.
interesting overview. And we should organize a meeting for TUGS students about obesity, because you really well explain what obesity means, how to treat it, and how to sensitize the population. So we should organize. Thank you, Professor Tawa. Thank you a lot. And Dr. Baru, are you here now?
Yes,
can you hear
me?
Yeah, thank you. Okay.
Okay, let me see if I can share my screen. Just 1 second, share screen. I hope now. Okay, I think you can see my screen now. 1 second. Let me arrive to my presentation. Okay. Do you see my screen?
No, Dr. Baru, we cannot see it.
Okay, let me try again.
Thank you.
It should work now. Let me see. 1%. So I'm trying to do the share screen. Okay, no. Okay.
Okay, now it's working.
Yeah. Okay, so it's a very, very big pleasure to talk about. Even if we have to change the order, I will speak about bariatric surgery, and maybe it's a little bit better that I speak after the previous presentation, because I want to tell you about bariatric surgery, which is the most efficient treatment for obesity surgery. And unfortunately, the previous presenter couldn't speak about all the program. Maybe next time, I hope so. But my idea is to present that laparoscopic bariatric surgery is safe even during the phase 2 or 3 of COVID-19 pandemic, not only in Italy, but maybe after you see my results, maybe all around the world. I'm a consultant surgeon at University Sapienza of Rome, Italy. And this study was a multi-center prospective observational study implying 8 very important bariatric centers from Italy. And what we know about Italian pandemic and obesity. The first interpersonal transmission of the SARS-CoV-2, the virus that it's affecting our lives, in Italy was registered in the beginning of February last year, and up to middle March, all the bariatric procedures were suspended. Up to today, almost 5 million cases were recorded in Italy, and more than 133,000 correlated deaths. From these, obesity was identified as a risk factor in 10.8% for both genders. So what happened in Italy, as all over the world, from March to May 2020, there was a stop of elective surgery, including bariatric surgery. And then from May, we started to open, let's say, the so-called restart moment, elective surgery with class A and B priority, including bariatric surgery. And then we had the phase 3 when it came the second wave of the pandemic from October up to May 20. So we know that obesity is a chronic disease, progressive, recurrent, debilitating, complicated by so many comorbidities, induce a procoagulative and pro-inflammatory status, and it's associated to a higher risk of infective disease, especially of the respiratory tract, with an increased risk of ICU, intensive care unit access, and intubation. Because of this, it has, and not only, it has an important role in the SARS-CoV-2 infection with a higher risk for complicated pneumonia. That's why they call obesity a pandemic within a pandemic. So we started to do immediately in March 2020 a retrospective multi-center study evaluating the risk of SARS-CoV-2 during the first procedures that we did between January and February 2020. And we chose a control group of bariatric surgeries performed in 2019 in the same period, January, February. And think about that period, nobody knew about the infection, the disease, about COVID-19. So we identified 5 patients positive for SARS-CoV-2. And all had a good complete recovery. And the postoperative complications between the group 2020 versus 2019, there was no difference without any specific precautions. Afterwards, a lot of literature came out with the idea that all these obese patients might be safer through surgery because they are obese people suffering from a lot of comorbidities that need bariatric surgery for their diseases. And but most of these recommendations were, let's say, theoretically. So we thought to do a practical study with some aims. Primary endpoint was to evaluate the 30 postoperative days mortality morbidity from SARS-CoV-2 infection in hospital in order to evaluate the efficacy of the in-hospital protocols and to minimize the risk after elective bariatric surgery. And in the meantime, the secondary endpoints were to evaluate perioperative readmission rate, reintervention, and the infection rate among the healthcare professionals. That's why we involved 8 high volume bariatric centers from Italy. Think about that Italy was the first country in the world that was hardly affected, it was very affected by the pandemics. So we involved centers from North Italy, which was the center of the pandemia, and central of Italy, where like Rome, very affected in those days. So our inclusion criteria: no previous SARS-CoV-2 infection, primary bariatric surgery with no concomitant procedures, except hiatal hernia repair. We do this very often. Obese patients suffer from hiatal hernia, yes. And we estimated the time of the procedure less than 120 minutes. We wanted to operate in this phase patients, let's say, with less problems, with a specific informed consensus for bariatric surgery, COVID-19, and study participation. We had very strict protocols. Of course, we started to make happen with these protocols. In the beginning, we didn't know what to do. Then we start to adapt. So before hospitalization, phone check to exclude symptoms and positive contacts. The test 24 hours before hospitalization. In hospital, social distancing, use of protective, all the things that we usually use in the hospital, test at discharge, in operating room, of course, protection, aspiration systems for smoke, air filters, limited access, senior consultant operators in order to minimize time use of the operating room. And after discharge, follow up by phone on the 7th and 14th post-operative day, and outpatient control after 30 days. So the results, enrolled patients 1,258 versus 1,451 patients, almost the same number of patients. At discharge, all with negative tests. I insist this 1,451 patients were operating the same period of 2019, and this is what we enrolled in 8 centers in the between May 2020 and January 21. So in all this period, we had only 8 patients positive, 0.6. Only one was admitted to infectious disease department, but with no comorbidity, no complications, and no correlation between patients and healthcare professionals. We couldn't demonstrate there was any correlations. We had 15 positive healthcare professionals, but again, it wasn't correlated with the patients. It's very hard to demonstrate this because all these professionals are working in a lot of departments, not only surgical, but emergency care and ambulatory and so on. Speaking about the secondary endpoints, we did more sleeves and less gastric bypass. And I can say that we had to operate less, people were less sick than comparing with the same period when we speak about comorbidities. About complications, there was no difference when we speak about complication altogether. We had less fistula in this period, but probably is influenced by the less numbers of patients operated. Only anastomotic bleeding, there was a statistically significant difference, but for the rest of the complications, we could not find any difference between 2019, when we had no COVID, and 2020. And all complications were successfully treated with no mortality except for the pulmonary embolism. We published recently this study with the conclusion, which ending my presentation. The introduction of strict COVID-19 protocols concerning the protection of patients and professionals guaranteed a safe resumption of elective bariatric surgery. The prevention of in-hospital infection was obtained. The safety profile was also maintained during the second and third waves of the outbreak. Now we are facing the 4th outbreak, but it's allowed access to a cure for the obese population. And considering the actual pandemic situation and the Italian epidemiology, the present data support the weight loss surgery program, not only in Italy, but worldwide. Of course, there are some conditions like vaccination, both patients and professionals, telemedicine, in-hospital protective and preventive tools. All these might enhance the safe profile of bariatric surgery, considering that per se obesity represents a negative prognostic factor for COVID-19. Thank you very much for your attention. This was my cooperative restart group. And I'm very happy and very honored that I could present our work here.
Thank you, Dr. Baru. Thank you a lot. Like, I'm from Sapienza, so I'm really honored that sometimes Sapienza is here.
So how come we haven't met yet? Okay, that will be a lot of time.
We have a question. Okay, Dr. Sharif is a he's speaking about his experience. Yeah. They stop all bariatric surgeries doing COVID weights. Yeah, I think this is like.
Yes, I can see here the question. We had to stop all bariatric surgery and do COVID. Yes, we like I showed, we stopped in the first waves, and then the next waves we had to stop, like say for 2 weeks, 1 week. It wasn't the same. I mean, all the regions, all the hospitals reacted in order to protect the local environment. We had this opportunity. So some places were more affected, like Turin and Milan hospitals, but starting from last year, we could operate almost all the time. Of course, less activity, more protection, more let's say safety protocols. Now we had to, let's say, if we had to operate 5 days a week, now we operate only 3 days a week. What's important that we could go on and we could offer to the patient a safe environment. Like I said, only 0.6 developed the disease after the operation. Okay, after the first 14 days after hospitalization. So
very interesting.
It was
very interesting data.
Great.
Yeah. Thank you, Dr. Baru. Thank you a lot.
Thank you.
I want to thank all the moderators, Dr. Soon, Dr. Gal, Dr. Dasari, and Professor Tawa for his keynote lecture. And I'm going to share with all the presenters the certificate in the next hours. And so thank you a lot for being here today with us, and enjoy your Sunday. Thank you a lot.
Thank you. Bye-bye.
Bye.
Thank you.
Bye-bye.
Bye.